Good to go. We're good to start.
Yes.
Excellent. So colleagues, I see there's a number of colleagues already online. It's a real privilege for me to welcome you all today for the school's noon meeting. With me is Professor Mosedi Namane, or as we know her so well as Sedi, or Prof. Namane. Our turn from family medicine to present at the school's noon meeting, where, as you can see on the logo of the advert, the school is now called the School of Public Health. And underneath, you are seeing that the Division of Family Medicine now in the Department of Family, Community and Emergency Care, or FACE, Department of FACE. So it's an interesting juncture where we retain our strong relationship with our colleagues in the school, but we are venturing into a new department with new colleagues and collaborators. But I think it's important, especially for this topic today, that we have this combination of clinicians, but also the public health and community health perspective, and the health, especially the health system improvement perspective, which is really the interface of family medicine as providing clinical care, but also strengthening clinical services through clinical governance. So with me, Prof. Namane, as I've mentioned, is an esteemed colleague and has been working in our division for, I don't know, we're not going to give any numbers, not divulge any of those intimate secrets, but what I am allowed to share is that she's a joint appointee with our division and the Western Cape Department of Health and Wellness. She has really been recognized for her role in pharmaceutical stewardship at the provincial level, and has been appointed 4 times already by the head of the department at provincial level to serve on the PTC, the provincial or the Pharmaceutical Therapeutics Committee. And basically, this is a key governance body that looks at the use of medicines in the province. And she's also serving on this provincial PTC's EXCO. She's also a member of the MUE, the Medicines Use Evaluation Committee, a body that was already founded in 2014, that looks at tools to promote rational medicine use. Another key aspect in terms of governance and cost savings. And all these activities, the team and herself has received numerous awards for them, including in 2017 a special provincial award for the team, and in 2020 an innovation award for producing an impactful MUE tool. At a substructure level, she's also serving as the chairperson of the Southern and Western PTC. And as we know, she has so many other leadership roles in the service-related work, for which she was honored in 2018 as the Premier's Best Frontline Public Service Employee. We know of many interests in scholarly pursuits, but it's important to mention her interest also in community and primary care rheumatology, for which she has already written a number of chapters and other useful guiding documents. And excitingly, she's also Lancet Commissioner for osteoarthritis in primary care. And since completion of her MSc Clinical Epi in 2017, she has considered herself as a clinician researcher, so bridging clinical practice and scholarly pursuits, and really is a role model for us all. She is an established researcher and has a Google H index of 6 and citations of 459. So, Prof. Namane, it's really a privilege to welcome you to this noon meeting, and then we look forward to your presentation. With this one to there we go. Over to you. Thank you so much.
Thank you. Introduction. Yeah, as a disclaimer, ahead of time, I'm going to be presenting work that has been generated by a collective. So, and the Provincial MUE Committee, and those are their names. And you'll see a logo of the University of Western Cape, who've been, our main stakeholders in our work. The talk is going to be on the background of MUEs that have been done in the Western Cape to improve systems for rational medicine use. And then secondly, then I'll describe the journey for safe PPI use. The definition of MUEs is that it's an ongoing, systematic, criteria-based program of medicine evaluations that helps to ensure appropriate medicine use. When I say criteria-based, they are evidence-based criteria. So we use a criteria from our national standard treatment guidelines. We first define the standard of care and the threshold when we do an RMU. We want to know ahead of time, this is what we are measuring things against. This is the standard. And I'll show you an example as we go on. So that's an important part of the MUE that has to be in place. Then the next thing will be assess whether we're prescribing in line with evidence-based guidelines. Okay. Then the next thing is, once we've done everything, ultimate aim or the objective really is, after we've collected our data and we've analyzed and we've done things, we want to prepare appropriate interventions that are meaningful and that's feasible, things that can be done. And you'll see an example of how we do that. And then in summary, it's basically to tackle misuse of medicines. And the medicines, it can be because of people reporting that there's high use of the medicine, or there's high costs of the medicine, or that medicine has got high risk, and or is problem prone. And that can be administrative when you say problem prone, like we can't source it, or that's a problem. Okay, so things like that. So it's a wide look at medicine issues. So now we subject whatever medicine, okay, has been put forth. It will come through our provincial PTC and whatever. We'll get a noise from everywhere. People, pharmacists complaining, doctors complaining, other specialists complaining about these medicines or whatever. So when there's too much noise on the medicine, okay, so we will firstly subject it to something that is called, or our pharmacists will subject it to what we call ABC analysis. Okay, to see if it's a real problem. So they're going to measure it to see, okay, is it high cost, is it misuse, or just from, you know, like crude data. Once it passes that it's really, we're thinking it could be a problem, then we will subject it, the MUE, now it's taken to the MUE, and the MUE subjects it to what we call a MUE matrix. Okay, and this is the example of the matrix that we used in 2014-15 when we started, and these are the medicines that were issued that passed the EBC thing. Okay, so not only the medicine, the first item there that you see the it's blood glucose statistics. Okay, in the previous financial year, they cost 23 million. Just, do you see what I mean? That's a lot, okay. So what, and then the quantity of the sticks. So what we do is we score the medicines from 0 to 2. 0 means that it's less likely to have that high use or high cost risk or whatever. And then 2 being most likely. So it's a consensus thing. If you sit in your together and we'll say blood glucose checks. Okay, for instance, you'll see everywhere I use 2, that's the ultimate. But does it have risk? No, we actually want to have it. So that's why it says 0 there. So then we'll have a total. And then you'll see, interestingly, there was aqueous cream, because all these groups have got aqueous cream, okay? But you'll see that, I mean, when we subjected it to the matrix, our score was 2.5. And so, okay, you'll see, okay, there's a 7, 6.5 and whatever. So that's how we assess, you know, the cost. Sometimes the medicine we expect it to be expensive. So we know that in terms of the ABC, it's the one that we spend 75% of the budget on it. So then it's fine. Okay. So that's why that has to happen first before we come to this. So now you'll see at the outset, we also had comments. For instance, something like etapinam, carbapenem, it's an antibiotic that is supposed to be used for serious nosocomial infections in ICU. And it was being used, we felt that was too much, okay, for that. But we said, okay, let us give it to the pharmacology registrars to do an MUE on it, you know, because it's at a higher level of care and the issues around respect and things and whatever. So, you know, we strategize on how we will do things. So we don't leave something, but we will do something about it, but work smartly around how to address that. And then some of the things like CDU, for instance, I mean, aqueous cream, we just said, okay, let the CDU tell us which facilities are using it, because they can draw the thing. And then we just approach those facilities and inform them. We don't need to do a huge MUE on it. We can just go and tell the people that, okay, it's only for people with eczema or ichthyosis or something like that. So that's the first thing. Now, just in general, this is a generic template, the method of doing. So once the medicine is passed, now we're going to do. There's a methodology that is internationally accepted. So we have a design, okay, and we decide whether it needs a retrospective or concurrent or prospective design. Then there are facility selection, and we determine the period of evaluation. Usually, we've been doing over a 3-month period. But we can decide, it's just that it's feasible for us. In other countries, people can save over a month if it is feasible for them. Patient folder selection, we like structured, you know, it must be selected by chance, so that it's more meaningful. And then we determine the inclusion and exclusion criteria, and we get the ethics approval from the Western Department. So, okay, the MUE team is multidisciplinary, and then that's why we are able to put our heads together when we're designing a tool. So the tool is centrally developed by us, and it's standardized, and we know that it's trainable, and it's feasible in that it's within the normal functions of the pharmacists or the clinicians. And it's in their job description of the pharmacists in the Western Cape. So it's feasible.
Good job.
Then the data collection sheet. This is what we started, our first one when we started with aspirin. Okay, it was a tick sheet. The criteria, you'll see that we've got the approved indications as per standard treatment guidelines. then other indications, contraindications, and then the doses. You can add other things that you want, but we wanted for that. That was the time when aspirin was prescribed for everything and was causing harm and whatever. So we started with it. But the binary response, the responses are binary, is yes, no. So it's an easy thing. And tick boxes. And here you'll see, I mean, it's a clinic. There's a place where you have the patient's demographics, and this is folder 1, folder 2, folder 3, folder 4, kind of like that. And basically that's how it's designed. Now, as we moved on, we became more smart, clever. Now we've got an electronic version that was developed by one of the young pharmacists. And it has got the same thing, but it's smaller, and it has got a drop-down menus. So the criteria are here, and then you can choose. You can see here for folder 1, the patient was given amoxicillin for dental abscess and caries. So they chose this one. This one, it was for tonsillitis. You see, this was for amoxicillin clavulanic acid when it was being misused. So it's still the same thing, but it's easier. It has got drop-down menus, and it will show you where there's green, you have to complete that. And if you submit it, and if there's something that is red, it means you haven't completed. So it comes to, it shows you. So it's kind of like a smart thing, and it's interactive. And as a result, because of that, we are able to include other things. For instance, if you are interested, if a patient is also on HIV medicines or it's on one, so we can add other things. But the main thing is the standard treatment guidelines should be there. We must still get, that's the main thing, but we can add other things in. Okay. So our tools are, and then the good thing is that when you click a button, it analyzes for the facility. You can have your graphs or whatever. So even before the data is collected centrally, you know for your facility how you are doing. So you can start correcting things and whatever. So it becomes much more interesting. So some of the MUEs that have been conducted so far are those ones that I've listed. The one that we started, I think it was a good thing that we started with aspirin. Aspirin was a problem for everyone, so it engaged everybody. And we sampled throughout the whole province. You know, so you can see the sample size is big. And within 6 months of having done that MUE, there was a saving of 5 million rands for the province. And you can imagine also, this was just in cost of the medicine, but what about gastritis, peptic ulcer disease, and all that, because it was just prescribed for everybody. Yeah. So this is the one that we got a special award for. Okay, and it gave us more oomph to do other, you know, because, so this one was MUE on steroids, and it was pleasing results and everything. So we've done others, and then I'm going to be now discussing the PPI. Okay, but okay, you will see the results of the MUEs. People have presented conferences, there's been publications around them, and policy changes. For instance, core amoxiclav is no longer being used because of the resistance now. We had to change the UTI. We've got a new organogram. I'm sure you've seen that, revised guidelines. And it's because of the MUE, you know, and working with microbiologists and whatever. So, and then the lamotrigine is the one that we are doing. It's the first one that is prospective, because it's a very difficult medication to titrate on a public health platform. So the pharmacists, when you start prescribing it, they can because they subjected to an MUE. So if things are not done correctly, they send it back because the titration has to be according to one. It could be a harmful medication. So that's why it has got a prospective MUE. So now we come into, you understand the background of MUEs. Now I'm taking you through the journey of the PPIs, okay? That was not as nice as the aspirins, okay? So the indications were lots of noise around, okay, it's causing adverse effects. We've read in the books the hypocalcemia and osteoporosis and whatever. Okay. And then ABC analysis, true, it was costing more than 1 million packs in the previous annual year. I mean, for a medicine that is not, that was just introduced recently, it's a lot. And then the expenditure, 11 million. And then, and also the pharmacists were saying they feel it's inappropriately prescribed. Okay, so then I'm not going to go into the aim and objectives are the same as we wanted to identify areas for improvement in its prescribing. And then our criteria should be according to the standard treatment guidelines, and then results, recommendations, and then we'll see whether it will influence policy, circulars, and so on. So design, okay, same as that generic, but you'll see here facility selections. We wanted facilities where there's a doctor and the pharmacist, so not the small clinics where only there are CNPs. It's just to understand what's going on. And we also excluded where there was low PPI use. We won't include that facility. So adults, and then each facility 30 folders and collected. It was a retrospective collection of data over 3 months of the previous year. Okay. So these are the standard treatment guidelines, the indications according to the EML. Yes, no, now here it's unlike for aspirin, where when we said, okay, when we determine the thresholds, for aspirin, we said, appropriate prescribing exactly 95%. It must be as per EML. Okay, duration of treatment as per so everything for it was 95%, 95%, because obviously, I mean, things can be 100%, so 95% is very good. That's, you are strict. But now when it came to this, when, for instance, we know PPIs are used for gastritis. Gastritis will include soy brand, heartburns, all those funny hair and whatever, all those were put under gastritis. It was very difficult for us to put it at 95% because basically we had a guideline that was saying, because there was no capacity for gastroscopy. So there was a guideline that actually said, if someone is younger than 50 years old and has been troubled by GIT symptoms, but that are mild, and there is no alarm signs or whatever, you can put them on PPIs until they get a scope. So a scope can come after 3 years or something. So do you see what made it murky? So that's why it was. So after just discussing and looking at the CDU and whatever, we decided on 65%. It was an informed 65%, but I'm just showing you why it was low. Okay, and also for gastroscopy, similarly, came to 70% because of that. Okay. So this one is murky, but then it tells us when the results come, we shouldn't be too whatever, because we know we are in a murky climate. So now there's our sample size. You'll see people who should participated are these ones. For those who don't still get confused about what CDC, CHC, maybe let me just do it. A CDC is a provincial clinic that is an 8-hour facility. It's community day clinic. When they say just clinic, it's a City of Cape Town clinic. Those are the definitions of the word. When they say CHC, it's a 24-hour provincial facility, like Vanguard. Okay. And these are district hospitals. And so from, okay, metro, rural, look at these percentages are not 100%. It's just because it was not captured, things were not captured properly. So that's our results. That's what. And then you'll see females, their health-seeking behaviors. And most of the time it's like that at primary level. We see more females than there are males, even if it's random selection. And then that's our mean age. So coming to the results of what we used, look at this. Soy brand, whatever dyspepsia, 20%, a big number. Okay. This reflux disease, almost 50%. So both of these 70% already that is used in here. So already in a space where we don't have gastroscopy and whatever. So it already tells you we need a lot to sort out this thing already ahead of time before we can do proper recommendations. How do you recommend in an environment that is making? Okay. And then now here you'll see the non-EML indicators. Stress ulcer, okay. Stress ulcer, how in someone who's not hospitalized or whatever, but okay, okay. Cardiovascular protection. Oh, yeah, okay. So there are studies that say others are not inconsistent, whatever, but it's not something that we classify as evidence-based, whatever. So it just came, no indication. People are just getting and getting. There's no indications on why. Just being repeated. That's a big number of this. 13.5% of that. That's a big number. And then other, it's things like we suspect that the patient's hoarseness is probably from reflux, which was a good thing because it made me to think about that all the time now when I'm seeing patients. Yeah, so it's things that kind of made sense why they were there. Okay, so we put them under. So now, this one, management of peptic ulcer disease, we were expecting, if we were just looking at it, the threshold for this, we'd want them to be 100% for this subsection, peptic ulcer disease. Okay. So there were 127 that were reported as active peptic ulcer. Gastroscopy performed only in less than half of them. For active peptic ulcer, there is access. You know, so we expect it to be, I'm just, now, of those that only 59 had gastroscopy, so that's not good. So now of those that had gastroscopy, in the folder, H. pylori positive and H. pylori negative. This, we were expecting this to add up to 59, and it wasn't. So what about those who are not H. pylori positive who needed to be on antibiotics? Because remember, the pharmacists won't give their. What happens in our system is that they do a biopsy and a patient is sent home if they're established, okay, and then we get the results. So if we don't do justice to those results, then this one says H. pylori and treats that. Because of antimicrobial stewardship, we will not just put people on antibiotics, okay, because some are H. pylori negative. Okay, so you can see that there's harm that's happening to patients. What about, maybe there are some more positive that ended up not getting. And then here, okay, so of H. pylori positive, when you look at appropriate antibiotics that are in the EML and the duration and whatever, only less than half of them were the correct antibiotics. Either the antibiotics themselves or the dose or the duration or something around it. Okay. So, and then here, when we added NPPI, we look at NPPI. 3 out of 70. So, and here, when you look at this subset, this is the one that needs a threshold of actually 100% because everything is there. If we were for everything. So, okay. Okay, our recommendations were not okay. This is what they, I'm not going to go through them because as we were sitting down and trying to do the recommendations, we were saying the bigger picture is that the majority of people don't get access to gastroscopes. You know, you don't want, remember that according to, you know, correct medicine, you are supposed to, if someone has got symptoms for more than a month and maybe they are not responding properly or not cured by PPI, they should go and get a scope. Okay, so even if it's not peptic ulcer, what if there's an ulcer there? What is Barrett's esophagitis? What is the, you know, all those things. Yeah. So, okay, our recommendations really, we're just talking about it, but as we're presenting to people and presenting, and then we came to a conclusion that we need to call our friends. We need to go and speak to gastroenterologists who can help us to come. Okay. So this, unlike the aspirin where we could do everything ourselves and do things, here we needed others to assist us. And then also we had an idea because in Canada, they've got what they call a deep prescribing ways. And one of the big deep prescribing programs are for PPIs, but it's evidence-based. And it was agreed upon by the country that this is how we're going to be doing it. So we went with them with that idea as well. Okay, to the table, say, can we use this once we are maybe improving capacity or something? What can we be doing better? And so after many cycles, okay, we came up with this, with the gastroenterologists in the face of not having sufficient gastroscope. How can we go about? Okay, so we developed this PPI algorithm, which is now in a circular, by the way. And my students and doctors at Venga did participated in this because they would put it to test. And our doctors also were looking at it. Is it reading well? Does it make sense? And students would be, anybody with a PPI, they put it to test and see, is it working? Is it doing this? And all. So we refined it, you know. And then this was during COVID when this came about. Okay, yeah, during COVID, and we didn't have enough patients. But then we got our rehab students to identify patients because their patients have got pain. And so majority of those patients have got PPIs. So it also helped, you know, refer patients, and then we can try and see, do they really need it and whatever using this. So when you look at it, so there was a lot of thought of thinking about it. If you look at it, it's a one page, but this is the first half of the page. page. When you look at it, we wanted it, when you look at it, it must look familiar. Okay, so the PEC manual is in this form. So there was, remember that people are using PEC manuals and whatever. So the first thing is about the alarm signs. That's how the PEC manual is like. The alarm signs went to people who need to be referred and who are in trouble. So that's the first part. And then here it just reminds you quickly of how to track the patients. Okay, please just make sure that you've got this, you've got that, you've got that in your notes. Okay. Then at the outset, counsel on lifestyle. Our students were using their up-to-date articles to, for how much to eat, what to eat, and when to eat. The PPI, if you're required to be on it, when to take it, away from meals and things like that. And also when you sleep, prop up and whatever. And smoking, stop smoking and limit alcohol. So these things have to be in place as well. Now you will see at the top of the first thing is the indications for long-term PPI. This is patients who are already coming from them with Zollinger, Ellison, Barrett's, esophagitis, and some of these patients who are on long-term because of risk factors, they are on non-steroidals and they've got another risk factor. Perhaps they are over 65, you can modify them, so they're going to remain on that. Or when you stop NSAIDs, then you modify, you have to change things like that. But basically, these are not for long term. And then this was just to remind people the times of short-term PPIs, and gastric ulcer treatment is only 4 weeks, okay, not 6 months, 10 months or whatever. Okay. Duodenal ulcer is dead, with H. pylori positive 7 days, but with antibiotics. Negative 14 days without antibiotics and so forth. And this is in the EML, but just to remind people, and it's a one-pager, you can look at it and do the right thing. And then you stop your treatment. So then the bottom half is when you stop your treatment, some patients, for instance, for gastritis, that is for 2 weeks. Okay? You stop the treatment and you get a recurrence of symptoms. So you have to look at, okay, do you have risk factors or not, or alarm signs, refer back to them. No, if no risk factors, okay, you reinitiate, but when you stop it now, you must stop it, you must taper. Because of this concept that we never actually implemented, of when you stop PPIs, usually you have rebound secretion, hypersecretion, and you have, so this was included, okay, and people are now doing this, and I see that with our own patients that we follow up with students, that this works. Someone who's been on PPIs for 3 years, 4 years, whatever, and when they stopped it because there's no indication, they get symptoms again, but when we are tapering, you do get away with it. So this was also an educational tool as well. Okay. So here it's just to remind people that if for NSAIDs, if you don't have associated risk factors anymore, then you must taper and stop. Okay, so then we got a circular. We resulted with a circular, and that is inside that circular. That sheet that I told you about is in the circular of how to use PPI. Circulars are things that are documents that are respected. When there's a circular, in the Western Cape in particular, okay, it gets followed up. Okay, so we were happy that the work resulted in a circular. Okay, and that informs what people should be doing. Okay, so that's the top part of the circular, and it was released last year. And then the other thing is that there was increased capacity to access gastroscopy. You'll see for Somerset Hospital, I've just shown for Somerset, but other places, they never had anything. So here, you'll see, this is just the top half of the page. And then when you complete the form, it's done so smartly. because it will tell you if something is urgent, and then you will check for urgent, and then you email it, you'll get a sooner appointment. And obviously patients who are vomiting blood and whatever, that's emergency, they have to go in. So somewhat there's also increased capacity elsewhere. There is, while there is a wish to do that, COVID interrupted things because people are behind and whatever, but we are hopeful we can see things are coming up, and we are hopeful that once things settle up, that will be useful. And then the other thing is that recently South Africa came for me, this was the first time that I saw a bold statement about the adverse effect of PPIs. And this one is on, okay, you will see Big Pharma, everyone here, in collaboration with SAPRA. SAPRA is our FDA. Okay, so this can't get bigger than, okay, where they were warning us that there's increased risk of subclinical acute interstitial nephritis associated with the use of PPIs. And our patients, we've got a lot of patients who are just anyway having compromised renal function. So we must just be careful and weigh option when we prescribe how long. Obviously, where it's needed has to be given, but not just like this. So my personal reflections about the whole thing is, MUEs for me as a family physician in that space, it brings about, I've observed that there's meaningful collaboration with specialists from other disciplines. We've had other MUEs with neurologists and other people and whatever. And there's increased capacity besides prescribing better, but the referral pathways get more refined. It does more than just prescribing correctly. And our clinicians respect data. When they see data, they engage better with data. It's easier to talk to them. There's a generation of just high value discussions. People are not complaining about things, but they are offering solutions usually. When they speak, don't you think we should be doing this and not that? Yeah. And also I like the fact that there's a repositioning of the pharmacists to occupy center space in the use of medicines. Because when, and with respect, because when a script is sent back, nobody swears at the pharmacist like things that we used to keep in the past. So, I'm a doctor or whatever. No, there's respect around that. We work well together, respect each other. I enjoy including, I've told you, my students in MU, including rehab students, as I'm saying, everybody gets involved in that.
Why without meat though? Like that? How do you have a meal without meat?
She keeps going hiking.
Yes, I think so.
Yeah, okay, and then.
No, but what's wrong with eating meat?
There's nothing wrong with eating meat. What I'm saying is you have to pay attention to how what you eat makes you feel.
Sorry, can you please mute?
Jay, like, yeah, he's undecided. Like,
Sorry,
That's you see.
yeah. Sorry about that.
Yeah, okay, so the last slide was just, the last piece was to say, it's a great, a rewarding exercise because of the recognition and what you see and lots of work after hours and more and whatever, but we already know that, from previous experience that there are going to be rewards. Something good is going to come out of that. And we are being in a making environment, we know that we will come out somehow of that. It's not unsettling. Then the last thing is that some members of our team have just completed the first draft of a manual to guide MUE processes, because we want people to just design their own facilities And then the tools that we have now that we've completed are 12 and we're doing 2 more. No. And they're available to anybody because they are the tools for the province. So people can use, reuse, do whatever. And then that's the Jenny has the thank you. Any questions, comments?
There's a lot of clapping happening online.
Oh.
We still also have 22 or 23 people online.
Okay.
So let me just quickly, where is this screen? And then we can just have a look at those online so we can maybe hear what are any questions, comments from either online or in the room.
I think,
Yes.
Prof, I mean, with the PPI,
Yeah.
comparing it to discipline that we used to give before and then we had to stop
Yes.
prescribing.
Yes.
I don't know if this is a question or a comment, but it was easy for us to de-prescribe discipline because when I told the patient, okay, this is what we have found, that is why I'm stopping discipline. Patient were okay because they never felt that effect of discipline on
Yes.
them. So likewise, I think it will be easier if I'm to stop any of the hypertensive medication because they don't feel the effect
Yes.
almost immediately. With PPI now, I feel more guilty writing PPI because I know the side effects, and there has been quite a few studies saying that don't prescribe PPI, like
Yes.
But
you taper now, ne? So that the patient doesn't
I'm
have.
paper now, but at
Yeah.
the same time, it's very hard to convince a patient who takes like 1 tablet of PPI and suddenly feels better
Yes.
compared to discipline, and I think that is one of the reasons why it's not as successful as, or it might not be as successful as.
Yes. That's true. Yes, I agree with you. But I'm going to challenge you to do the tapering and see, because it's true, the patients, once they stop, they get symptoms when they've used it for a long time. And it's because of this phenomenon of hypersecretion that we have not, for me, I think I've heard about it once before, but it never sunk in. I even forgot about it in a consulting room. I never just thought about it. But now that you know, okay, and you can explain to your patients, and then we have given you the recipe of how to do it also.
Yes.
You know,
And I think that is
yes.
very helpful now.
Yes, that is evident. And then the other thing is give a patient a follow-up appointment. Don't do that and not give an appointment, because that's why they argue, because they are worried that at home, if something happens, what's going to happen? But you must contain them. And no, I'm going to walk with you in this journey. And you must, yeah.
I've got 2 comments. The first one is it's good to see you.
Thank you. Yeah.
The second comment is, and I can late, but I think I'm just getting the gist of the nature is that we're not over-prescribing PPIs anymore. We sort of, I think that's the gist of the nature. If I can just gather by the conversation.
No, it was not that. It's actually to prescribe it safely.
Safely.
Yes, yeah.
Because I've had the practice for a while away. When I modified it with family medicine,
Yeah.
you don't just give pharmacology
Yeah.
to the patient. It's also non-pharmacological management. So for a while, I've been telling patients, stop eating the foods that's giving
This
you
is what
heart
we were looking for. Yeah.
get active,
Yeah.
sleep, get your bed on 2 bricks, those sort of things. I mean, it's fun.
Yes.
But there's no point in taking the medication, but you still playing around with the fire. It doesn't work. So I'm
Yes.
happy now that I've got support.
Yes.
That the people is liking my non-pharmacological strategies also.
Yes.
Just giving the PPI.
You hit the nail on the head. Okay. That is why in our deep prescribing thing, I'm happy because you were not here, but you're talking about that, which means you are showing the gravity of the importance of that step. In the sheet, the algorithm that was put together with the gastroenterologist, that's the second step after excluding risk, people who need to go for gastro.
Yeah.
As part of your management, the lifestyle
Yeah.
is the first thing before the medicines.
Yeah.
Yes, yeah. And it's precisely what you are talking about.
And I got confirmation because I put a TikTok video out of that. I got 400,000 views, which means that people were like, wow, this really works.
Yes. Yes.
There's a hand.
Oh,
from the, please go ahead. The hand.
Who is that?
Hi, can you hear me?
Yes, please go ahead. I think it's Usha.
Ushma Smith is speaking. Hi, Professor Namane. Thank you so much for a fantastic talk.
Okay, yes, hello. Yes.
Can you hear me properly?
Yes, we can hear you.
Okay. Yeah, I just wanted to say thank you so much for this presentation. It's really such a neglected area. There's so much focus in discussions around access to medicines, but rational and safe access is really where we should be going around our discussions. And so I really think this type of work and looking at medicines use evaluations is really about maturing that discussion and debate around access to treatments. So I really think this is such an important point. And I actually think, I don't know if you're aware of the Provincial Health Data Center, but I feel that one of the untapped uses of that data center is to do medicines use evaluations on the entire provincial cohort, and to try and develop approaches where we can actually look at problem drugs and their prescribing in the province and see how, we did some work around that in valproate and really were able to find some real problems. And also, you raise the issue of lamotrigine, but also just to say that I think when we look at medicines use evaluations, we need to look at the entire class of drugs and see why there's certain channeling of certain drugs, and what the therapeutic alternatives are, and whether that's being, optimally looked at in a more holistic way. So just the 2 points was, one is that I think there's a big untapped resource in the Provincial Health Data Center to do this kind of work. And secondly, just to say that we might want to look at what the contextual issues are around that overprescribing of particular drugs or poor prescribing of particular drugs that will help us to improve, to have more targeted approaches to managing that. Thank you.
Okay, thank you, Ushma. Yes, yeah, your point is well taken. And in fact, as you're saying, I think this is the first time with the sodium valproate that we've been able to get access to information from the data center. And I think now, if they see the type of work that we are going to do from that, because I don't want to get into that much, but facilities or family physicians at the moment are using that data center to sort out the improper prescription of sodium valproate in women of childbearing potential. Okay, and we're using that data center, and that activity started actually from Monday this week. Okay, yes. So, and it's as a result of an MUE, but this came late, So we're hoping that once they see what we are doing with the information, the results that we'll get with that, we'll get more access of other data centers. But we are very grateful for that, and we are aware of that. Thank you for that comment.
Yes, I have a question.
Yes. Yes.
So my question is as regards to access to gastroscopy. So in this hiatus of freedom that I've had the opportunity to work in the surgical clinic here at the East River. And because I can do finding out aspirational and winding of biopsies, they keep calling me to join them. So most of the times when we see the patients there, some of them have come from their hospitals for an SOPD clinic referral. But the waiting times are so low. And most of them have come for gastroscopies, follow-up for gastroscopy results. And you find waiting there for 3 months, 4 months. And yet, even within the clinic, we give them again 7 weeks, 8 weeks to access gastroscopy. And in the meantime, as they wait, because I'm imagining when I was working bank, just to get that SOPD date,
Yes.
take 3 months.
Yes.
So as they are waiting for that, what do we do for them in the interim?
Yes, we said, you know, the main thing that disrupted services, even though there are hospitals that have increased capacity, was because of COVID. Then the other thing was the clogging up of the system with patients that are not supposed to be there. You know, there's a lot of that. Okay, so we need to do our bit from our side so that we only refer patients who need to be there and then they will. So I think things will unlock now that we've got space to do things. Yeah. Any other comments, query? I don't know if there are any questions here.
I don't see anyone
Yeah.
online.
We don't see
raising a
any.
hand.
Yeah.
No other
Yeah, there are
comments.
no comments here.
But I think we are almost at the end of the hour.
Yes.
But I love the conversation, and it was also afterwards, and I think also the linking of, I mean, the provincial view,
Yes.
what you're doing with the PPTC, the MUEs,
Yes.
looking at the provincial health data center, but then also looking at operationally what happens. So it might be also good to have the health services appreciation about, and what I also like about your talk is about the team approach that you developed in this of these guidelines and circulars. So I really want to thank you very much for this presentation. And what that does, yeah, maybe colleagues can also reach out to you if they have more questions or struggling to access the circular, or maybe
Yes.
have research ideas, because like you say, you're already involving the students with the MUE work at facility level,
Yes.
but it might be that there's need for some collaborative research projects with our Western Cape government partners.
Mhm.
And I see Mrs. Jasmina Johnson is also on the call, so not
Yes.
to put you on the spot, but
Yes.
it's so beautiful to have that collaboration, and what you represent here is, I mean, if we can hopefully have more of these type of collaborative team activities, bridging services, research, scholarly work,
Yeah.
but at the end of the day, strengthening the service for our patients, and making sure that there's a more like Ushma said, a mature approach, not just bean counting, but actually thinking about what does it mean for care. Place.
Yasmina, do you want to say something?
Maybe a final word of wisdom from her. Yeah.
Yes. Okay.
Hi, Sidi. No, not really. But thank you for allowing me. Look, we've really come a long way. With every MUE, we learn something new and how to do the process better. But just basically to mention, it's a pragmatic approach. It's not state-of-the-art research, but it's a pragmatic approach to allow us to understand what's happening in our facilities, especially when we have you know, not that, what do you say, those sophisticated technology sort of equipment and stuff like that. So what we have is what's written in the folder. Very often what's not documented, you cannot understand what's really wrong with the patient. But yeah, we are improving, and the MUEs are moving from strength to strength. And yeah, with every new MUE, we learn something new as how to improve the process. Thank you very much.
On that note, thank you, Yasmina. Thank you, everybody.
Thank you. Thanks for joining us today.